Welcome and thanks for joining us. My guests today are Bo Aldige, the CEO of Prevent Cancer Foundation, and Dr. Jim Mulshine, a professor at Rush University and vice chair of the board of Prevent Cancer Foundation. Thanks for being here.
Thank you for having us.
Wonderful. So today we are talking all about cancer prevention, and getting recommended cancer screenings is one of the best defenses against cancer. Screenings can help doctors detect cancer early when successful treatment is more likely, and some cancers can even be prevented with screenings. First, can you walk us through what screenings are available and how effective are these screenings?
Well, the ones that we know to be most effective are screening for breast cancer, cervical cancer, lung cancer, and colorectal cancer. At the foundation, at the Prevent Cancer Foundation, we also recommend people get an annual check of their skin for skin cancer, because skin cancer is a very preventable kind of cancer. Melanoma is a lethal form of skin cancer, and examination of the skin can detect melanoma before it becomes lethal. Mm-hmm. The reason that screening is recommended in the first place is, as you said, to detect cancer early when it is at a very early stage and can be removed most of the time, and the person is cured surgically. A couple of different cancers you also mentioned can be detected even before they become cancer. So precancerous conditions can be detected with colon cancer screening and with cervical cancer screening. So with colon cancer screening, before a person develops colon cancer, a person develops a polyp or many polyps. And those polyps can be removed, and the person literally, they don't progress to colon cancer. So that's one that's actually prevented through screening. The same with cervical cancer, which changes in the cervix that are precancerous can be treated, and the person does not progress to cervical cancer. So that's another one that is prevented through screening. With breast cancer, there is something that shows up on a mammogram, and so that's not precancerous. That is actually cancer. Nonetheless, we really strongly believe every woman should have the recommended interval for breast cancer screening. So at least an annual mammogram after the age of 40, or a baseline at the age of 40, and then annually at least after the age of 50. The holy grail for us is that there be more tests for more lethal kinds of cancer. And I'll just give you one example: pancreatic cancer. We know virtually nothing about screening for what's a really, really lethal disease, and on the rise, unfortunately.
Dr. Mulshine, I know we were talking earlier, and you mentioned some recent research came out that is pretty promising as far as lung cancer screenings go. Can you talk a little bit about this? I believe it's called the Nelson trial and its significance in the field.
Yes, I'd be delighted to. Lung cancer, as Bo said, is the leading cause of cancer death, second leading cause of death in our society, one of the leading causes of premature death. So in 2011, the National Lung Screening Trial was completed and reported by the NIH, and it showed that low-dose CT screening had a very significant effect in reducing lung cancer mortality. And that was a very big, important trial done from 2002, 2011, involved about 54,000 people. And it was remarkable because there had been 50 years of unsuccessful efforts to demonstrate that you could reduce that you could affect early detection of lung cancer. So it was remarkable, so remarkable that many people didn't believe it, especially outside the United States. And so the Europeans in the study group called Nelson that you just mentioned did a trial between Dutch and Belgian populations. Both of these trials that I discussed are in current or former smokers. They're different rates of smoking. But the point is that in both instances with long-term follow-up, they found that they could reduce lung cancer deaths by doing these low-dose CT scans on an average annual basis. And now these scans are important because they're relatively inexpensive. CMS reimburses for doing the scan at less than $100. They take about 3 seconds of imaging time. It might take 10, 20 seconds of the person's time. They can be read quickly, and these scans are finding early lung cancer the majority of the time, and so less people are developing lethal lung cancer. So this shift in stages that we're looking for has been achieved both in the National Lung Screening Trial and the European trial. Now, the European trial also included a small segment of women. For some reason or another, they have many more male smokers in Holland than they have women smokers, so they had a small component of women. At 8 years of follow-up in that trial, there was a 61% reduction in lung cancer deaths if you had lung cancer screening with low-dose CT, which is remarkable. That's somewhat close to about 3 times the benefit that we usually expect with our screening approaches. So this was an incredibly important finding, especially since women seem to develop more lung cancer for smoking the same amount of cigarettes. And women were specifically targeted by the tobacco industry back in the previous times. And so for us to have a tool like this now to find cancer at an early curable stage is wonderful.
And now, is this something? When can we expect to see this method from the studies be implemented in just everyday screening, or is it already?
It already is.
It already is. Okay,
Yeah,
I'm
that's
sorry, I
the
didn't
good
realize
news.
if that was the
Absolutely.
so.
It's recommended. It is. It's reimbursed by commercial insurance and by Medicare and Medicaid.
Great.
This is a great story about American healthcare because we hear about it's expensive and this. Well, the United States invested $250 million into doing a very well-designed trial. They demonstrated this first. They implemented it first. And everybody's looking to the United States across the world for how they can now follow this lead. So it's an example where our system worked in a very positive way that's going to help a lot of people avoid a dreadful circumstance.
Wonderful. Let's talk about age ranges for screening. And I know it might vary depending on the screening, but at what age should you start to be thinking about getting these cancer screenings? And are there any influences such as family history that might alter that recommendation?
There are influences such as family history, and if you do have family history of a certain cancer, the recommendation in general is that you start younger than that family member had the cancer. It's important to know that family history is determined by first-degree relatives. So if your father's sister had breast cancer, that does not put you at higher risk. A first-degree relative is a parent, a sibling, or a child. So if any of those had a history of a certain kind of cancer, then you should start getting screened earlier. The recommendation for getting screened for colorectal cancer has just been reduced. The age range has just been reduced to 45 because so many people between the age of 45 and 50 were appearing with colon cancer, and the recommended age had been 50 for screening. So that group was not getting screened on a regular basis. So it's been dropped already. Lung cancer screening, the risk seems to go up at about age 50, and it has to do with the smoking history. Cervical cancer screening, it's young women should start getting screened with a pap smear and an HPV test. That's called co-testing when you get both tests. And they should do that about every 3 to 5 years. And then we think annual skin checks, you can't start too soon, really, going to getting an annual skin check because people are out in the sun all the time from childhood, really. So
Right.
that's really important. And then breast cancer, the guidelines vary. On any given day, somebody's going to come out and say, "Oh no, well you should have your baseline at 40," or "No, you should wait till you're 50," because of what they call false positives, meaning something is found but it turns out not to be cancer. But it's really important just to stay informed and to talk to your doctor about and have a conversation to make that decision about when to get screened for these various. But the point is, you should get screened.
And the answer is that there's not a single correct answer, because we decide these things at population-based levels, and yet for an individual, their risk is either they will have it or they won't. So the people should not get put out back by these things. There's going to be differences because of cost, because of potential for harms, because of potential for benefits that is blended. And that's why the conversation with your healthcare provider, your primary clinician, is very, very important, because, you know, what we're talking about with prevention puts the individual in the driver's seat to make choices about your health. There are guidelines, there are reimbursements, but your situation is unique.
Thanks, guys. That was great.
Thank you so much, Rachel.
Thank you.
My guests today are Bo Aldige, the CEO of Prevent Cancer Foundation, and Dr. Jim Mulshine, a professor at Rush University and vice chair of the board of Prevent Cancer Foundation. I'm your moderator, Rachel Nania, on Invest in Your Health, sponsored by the Prevent Cancer Foundation on WTOP.com. Thanks for joining.